Hi, this is Tyler.
Hey, Tyler, Denise Jensen, how are you doing?
I'm doing well. How are you?
I'm good, thank you.
Good.
It's a beautiful day today.
It's nice to see some sun.
I know, isn't it? After all the cloudy days we had last week.
Yeah. A little bit colder this morning, but I will definitely take that if I can see some sun. So,
Me too. Absolutely.
and is anyone hanging out with you today, or is it just you?
It is just me today.
Okay. Can I ask, is my audio coming through okay?
Yeah, I can hear you just fine.
Okay.
No problems at all.
I've got this sweet dangly microphone and my
Uh-huh.
earbud in, and that seems to be my best my best bet when it comes to audio on this computer. So we'll just roll with that and see how it goes.
That works perfectly. I know I have to, anytime I'm doing Zoom, I end up having to get some sort of a headset or something because audio is more clear.
Yeah.
Hey, Tyler.
Jen, how are you?
Good.
Hello.
Hey, Tyler, Ann joined the call as well. Hi, Denise.
Hi, Ann.
Hey, Ann.
Jen R is also here.
Hello.
Hello, good to see you again.
Good to see you.
Rachel is stuck somewhere at a cabin, snowed in, so she will not be able to join us. So we'll give it a couple of minutes to get everyone online. I'll try to keep sort of the chat box up and ready for you, and it's recording right now.
Yep.
So we'll just give it a couple of minutes. Are we still waiting for Shoshone? There's Pam. Pam, can you hear us? Pam, are you able to hear us? I don't know if you're, yes, I can. Okay. Is everyone from Shoshone there, or do we need to wait a couple of minutes? Tyler, was Shelby getting on with you here?
I thought she would be on. Not sure.
Okay, so we got a pretty good number of people. So Shelby is not there. Okay, so
Okay.
you are on your own. Looks like Stephanie is a little bit running behind. She's with the patient. Pam, do you feel it's okay if we start, or should we wait for her? Yes, start. Okay, so go ahead. I'm going to put myself on mute and also off of video.
So what I'd like to do, I recognize a few of the names on the call. excuse me. Would it be good just to go around and do a little bit of an introduction, get a bit of background on who's on the call?
Yeah, that would be great.
Okay, I'll try to navigate it here. So I'll start with me. My name is Tyler Hemsley. I'm a pharmacist by training. Been working with Jen on a few different behavioral health and pharmacy integration projects over the last 6 or so years. So excited to be here with you today to talk a little bit about this idea of pharmacy stewardship, pharmacy practice in various settings, and then also dive into some of the opioid use disorder considerations. So happy to be here. Denise, if you wouldn't mind going next.
Yeah, Denise Jensen. I'm the program manager for the Center for Drug Overdose and Suicide Prevention at the Department of Health and Welfare.
Awesome, thank you. And Anne?
Yes, I'm Ann Daggett. I'm a licensed clinical social worker, and I am assisting CHU in distributing or helping with the iRopes grant.
Thank you, Anne. And then Camille.
Hi, I'm Camille Evans. I am with Valor Health. I'm the behavioral health consultant and working on developing the program here at our clinic.
Nice, thanks for being here. Jen R.
Hi, I am a biostatistician / data scientist, I guess, for CHU, and we had met over in Shoshone, so good to see you again.
Thanks. And Jen Y.
I think everyone knows me.
I figured if you wanted. All right. Pam, do we have audio from Shoshone, or not sure if? Okay.
Pam is saying no, but she's doing typing. Pam, is there anyone else with you? Is Wendy or any of the other staff with you? Just staff, okay.
Okay, sounds good. Thanks for being here. And then I've got S. Gallegos.
That's me. I'm Stephanie, and I'm a behavioral health consultant here at All Seasons, and then I also work for CHU as well.
Nice, welcome. And then I've got, is it Sherry Kuther?
Hello, I am Sherry Kuther, and I guess I should show you my face. Good morning. I'm the Director of Population Health out at St. Mary's and Clearwater Valley Hospitals, and oversee the behavioral health consultants and other members of our population health team.
Awesome. Thank you all for being here. I'll go ahead and share my screen. I'll bring up PowerPoint presentation. Checking on the size of that. Is that coming through okay, and can people see the screen?
Yes.
Okay, sounds good. All right, so kind of moving into, excuse me, objectives for today's webinar. So like I said, my name is Tyler Hemsley. I'm a pharmacist by training. It's been at least 5 years ago, Jen and I started working on some of these similarities between pharmacy and behavioral health in terms of our roles in the multidisciplinary care team. A lot of work with the clinic over in Shoshone and up in McCall, integrating pharmacy and behavioral health in various capacities. And so from a lot of that work, we submitted a few grant applications and were funded for a few different projects. And some of the things that came out of that work was this idea of, pharmacy stewardship. And so we'll dive into a little bit more of the background on that today, various models within the practice of pharmacy, and some of the value propositions that I believe that pharmacy brings to the table when it comes to this whole idea of team-based care and operating within a multidisciplinary clinic, and what we can bring to the table. Followed by that, we'll dive into a little bit more detail on opioid use disorder, some of the background and best practices, and how pharmacy can be involved in that therapeutic area. So, what I have found as I've worked in a few different capacities, I'll give you a little bit of a history in terms of my background and training as a pharmacist, because it's kind of a non-traditional track. When I got into pharmacy, I actually got a clinical internship over in Pocatello, and they took 2 pharmacy students out of the first year class every year. And so as an intern, I was able to work alongside pharmacists and pharmacy residents. A lot of them were faculty at the College of Pharmacy. We were in a really multidisciplinary setting. We had behavioral health in our clinic, we had primary care, we had anticoagulation management. And it was a really nice early exposure to shape my education, I would say. I was able to work alongside physicians and nurses and understand kind of the ebbs and flows of the clinical practice, and really saw firsthand what a multidisciplinary and an interdisciplinary team looked like and how it could function. Now, flash forward to, when I came out of pharmacy school, I realized that was far from the norm in terms of traditional practice. And so mostly what I saw in the community were the traditional retail setting, where pharmacists in your typical Walgreens or your Rite Aid or CVS, it's a very volume centric environment. It's very, very busy. A lot of times the pharmacists are monitored and managed about how many scripts they're able to push through per hour. And a lot of times they don't have the chance to really interact with the patient as much beyond really simple counseling at the pharmacy counter. And so when we talk about that type of a setting and then trying to coordinate that practice with a clinical practice, you can start to see how that might be fraught with some challenges in terms of the traditional retail environment doesn't share chart notes. They're usually not on an EMR. They're tending to practice in a setting that is pretty hectic and not very connected as it comes to the clinic. Pausing real quick, just from a coordination perspective on the webinar, Jen, I'm seeing things pop up in terms of, I'm not sure if it's chats or people joining. Can you give me an idea of if I should pause at any point here? Gen Y?
This is actually Jen R. For some reason, it looks like her phone thing is off, but I think it's just people chatting because she had asked if we could hear you. So we were just responding in the chat. Okay,
sounds good. Am I coming through okay?
Yep, you are.
Sorry, as I'm sharing, I don't have my chat screen open, so.
Oh yeah, no worries.
Okay, so moving through kind of basic retail pharmacy practice. The other main area of pharmacy practice that I was exposed to through my education was in hospitals. A lot of times in hospital pharmacy, the pharmacy itself is kind of tucked away, oftentimes in the basement or where it's convenient to have a lot of the medications in a secured location. Pharmacists are sometimes up on the floors working with physicians and nurses, but oftentimes, pharmacists are more involved in order entry and medication prep. Excuse me. And sometimes there's an opportunity to interact with members of the clinical team, but a lot of times pharmacy does, there is a little bit of separation there. And then what I've really tried to push forward, and this initial exposure that I mentioned in my clinical internship, apologize, I'm getting over a bit of a cold and I have a pretty good scratch in the back of my throat. So I'm trying to manage that real quick. Excuse me. Okay, so getting into more of the clinical practice of pharmacy. So sometimes we've been able to have a pharmacist integrated within a clinic or embedded within a clinic, and that happens in various capacities, and I'll get into a few of the different models later on. But over the last 50 years, pharmacy itself has undergone this really massive transformation from, if you take a look at the practice 50 or 60 years ago, pharmacists by law were not allowed to counsel their patients on medications. Getting a little bit of a feedback from someone's phone, sorry, little echo. And so as pharmacy has kind of moved forward as a profession into the area where, you know, pharmacists are really looked to as one of the most accessible and most trusted healthcare professionals, we've also bridged into the clinic in certain situations, and some of these practices have been going for, you know, 20 or 25 years in certain cases, where the pharmacist has really become this indispensable part of the care team, and acting much more in the capacity of a provider or a clinical resource on the care team, rather than just an outside entity being used to fill the prescription and potentially do, you know, a little bit of double checking to make sure doses are correct. So really kind of a transformation in the practice of pharmacy over the last 50 years. So excuse me. So as I've described a few of these different practices, you can start to see, as I come down here in the lower portion of the slide, sources of confusion and or quote unquote waste. When we talk about waste in the context of lean process improvement, identifying rework or areas where things are getting dropped, or we're having to, you know, we're having breakdowns in communication, that sort of things. So as we think about coordination among the care teams, there's a lot of opportunity for things to get, for lines of communication to get crossed and for patients to get confused, because we really have very, very disparate and different practices in a lot of these cases. If we're dealing from a clinic to a retail pharmacy, or potentially hospital to clinic. And then as we consider sources of confusion for the patients, they might have, excuse me, educational barriers. They might have functional barriers if they're, you know, if they have some issues with arthritis and they're having trouble actually, you know, manipulating the pill bottles or the Medisets, or potentially having some functional barriers in terms of access to the pharmacy or access to their medications. We'd like to take those into account. And then some of the time it's behavioral, where there might be certain held beliefs about their medications that maybe they're doing them more harm than good, or that the side effects are on the list of side effects. All of them are going to happen, and so there's certain educational and behavioral barriers that we may have to overcome. And then we could get into a whole nother conversation about what's going on with the financial barriers that may be in place when we talk about the prices of medications and the confusion around pharmacy benefit coverage and the donut hole with Medicare patients, and coordinating on all of that. So there's my point here is that there is a variety of reasons where things might break down in terms of communication, and really having a pharmacist as a resource to help navigate some of these things is a really valuable thing. So moving on, excuse me. within the context of medication reconciliation, as this is an area where pharmacists tend to play a huge role. And we think about this from a variety of different perspectives, but across the healthcare continuum, I think one of the things that is getting more and more recognized is that at the intersection of all these different providers and specialties, and patients even are getting a lot of over-the-counter stuff mixed in with their medications, there's an inherent risk as we add more and more medications onto a profile, not just from a drug interaction perspective, but a coordination perspective, meaning that if you have 20 or 25 medications on a list, treating 3, 4, 5 different disease states, there's a high likelihood that something is going to fall through the cracks. There's a high likelihood that the patient may be confused about which medications they're taking for which purpose. And in many cases, financially, they're having to choose between filling their medications at the pharmacy or buying groceries that month. And so it's a really rough position for our patients to be in, and one that is being increasingly recognized as a health risk as patients are excuse me, navigating this very confusing environment. And again, this is another, in my mind, value proposition for involving pharmacy in our care teams. And I already touched on this a little bit regarding the communication breakdowns that can happen even among a care team. So even within a clinic or within a hospital, coordination is key and communication is key. And then, excuse me, that'd be within a care team, and then among care teams in terms of coordinating amongst a retail environment or a hospital environment. The idea of transitions of care is another area where the breakdowns in communication often lead to hospital readmissions or adverse effects due to problems with the medications. So onto kind of this idea of a value proposition of involving pharmacy. Really, in my mind, we've identified a lot of different areas across the healthcare continuum where by involving pharmacists and improving the level of pharmacy stewardship that we're providing across this continuum, we can really accomplish the 4 components of that quadruple aim. Improving quality of care, lowering total costs, improving satisfaction of the healthcare provider, and then improving the health of the population. So one of the things that I kind of breezed through was that component of improving the provider satisfaction. And in a lot of cases, these patients who have 15 to 20 medications on their list, we're treating 4 or 5 comorbid disease states. A lot of times there's a behavioral health component. These are patients that can really derail a clinical day for a provider. But by incorporating elements on the care team like behavioral health and like pharmacy, we're able to assist that provider and make it so that it doesn't derail their day in the same way. We can put a pharmacist on making some sense out of that med list and potentially coordinating with behavioral health on some of the needs there. So, excuse me. So, pausing real quick. Any questions on the background and kind of that value proposition of a pharmacist? Okay, hearing none. We'll move into a description a little bit of some of these integration models. Excuse me. And so, as I said, I worked with Jen on a few different projects over the years, and we've had experience in a few of these different models. and there's strengths and weaknesses to every one of them. And it's not that I'm here to really promote one over another. It's just really what I've learned is the most important thing is to kind of take stock of what the needs in the environment are, what resources you have, and what you can potentially coordinate to make it work for your region or your area. And so just describing some of the different models here, we could start with kind of the least embedded or the least integrated. And that's kind of this context of remote support. Excuse me. One of the opportunities that I feel like we have is to really identify who your players are in your community. And a lot of times you might know that the entity exists, but you might not have a real strong line of communication to potentially your local community pharmacy, or local independent pharmacy, or potentially to if you're a clinic, potentially coordinating with the pharmacists in the hospital in your community. A lot of times those are really, really excellent resources that if we establish those lines of communication, we can really start to coordinate better as we go through these transitions of care, because oftentimes we're caring for the same patients in just a variety of settings. And so understanding what you have in your community and what resources you can connect into is a huge first step. And really those communications and coordinations don't necessarily have to be formalized in any kind of business sense, but it's just recognizing how to coordinate and communicate among the resources that currently exist. I'm going to skip over the second two bullet points in terms of remote support on telehealth and referral for multiple sites, and pop back to those a little bit later. But the idea of a co-location where we have two distinct entities, but they might share the same space. Now, behavioral health has actually had much more experience with this idea of a co-location than pharmacy has, in my experience. But we do have an example of co-location where we might have a pharmacist who is working for a different business entity located or being shared into a clinical environment. And sometimes that pharmacist might be operating on a different platform from a documentation standpoint, and other times they might be sharing an EMR. So this gets into the context of what it means to be embedded and integrated. And so a true embedded model is where you're working on the same team, same entity, sharing the same clinical record, and it's one and the same. Whereas you can have a highly integrated co-location model where you've got two distinct entities, but if the business model makes sense and both parties are amenable, you can do things like shared access into the medical record, and the communication becomes much more seamless, and it feels much more like a fully embedded model. Now, with a co-location or an embedded model, sometimes it makes sense to bridge or extend that model via telehealth services or referral support from multiple sites. So I'll give an example of a practice that we have over here in Boise. So we've got a clinical pharmacist who is embedded and integrated into an internal medicine clinic. And she takes referrals from all of those providers within that specific site. She also supports referrals from a neighboring family medicine clinic and another internal medicine clinic that is a few miles away, just in a different part of the valley. The geographic location allows for those patients to travel very easily into that one physical location where the pharmacist is located. So she actually acts as a referral support for multiple sites. In other models, specifically with the VA, they have deployed telehealth models where you might have a pharmacist operating from a hub and rural clinics being supported via a telehealth model, which has got its challenges and its benefits. in coordination, but it is something that you'll see out there in order to extend a scarce resource. Excuse me. Okay, pausing real quick, questions and discussion. And I would actually like for this to be an interactive portion of the presentation, to just pause real quick and talk about what experiences you're having or you have had in your own areas, so that we can kind of open this up and make it much more applicable to your specific sites, rather than just kind of a generic overview. So please chime in on any of these topics, and love to hear about where you all have found successes or challenges in these models.
This is Stephanie Roberts over at Shoshone Family Medical Center. We've had the privilege of actually working with Tyler and on a pharmacy integration project, in which we have a clinical pharmacist on staff with us a couple of days a week. And I can say a few things. One, Shelby, our pharmacist is Shelby, and at this point, she's a completely, I don't know how we go back to not having a pharmacist on staff, let's say that. She is used, even though she's here only 2 days a week, we use her several times by calling, because she works at the local pharmacy. To give you a kind of a layout, we are, we work with a local independent pharmacy, and we contract Shelby's services through them. And then she's on site with us 2 days a week, and she documents actually within my chart note. And we use Shelby for everything from polypharmacy to getting patients medications. Since the, a beautiful example is since the Medicaid expansion, we have several patients that are, have been on medications, and now because they now are eligible for Medicaid, there's all these prior authorizations and kind of workarounds that Shelby's just kind of taken on for us and taken off of my, staff and my plate. And patient-wise, patients love her. I don't know if Pam has anything else to add about Shelby, but
she's been a great fit. Her personality fits our clinic very well, and yeah, I don't think we want to go back to not having her here. So we've been trying to figure out ideas to expand her services in areas that she can help. For instance, she runs some registry reports and high-risk medications. She can do recalls on those patients. And she also helps with our Medicare wellness exams. We're going to have her start working on some diabetes care and some chronic care management also.
Awesome. Thank you. It's been, for me, it's really been a privilege to work with the team in Shoshone. It's an amazing group. So it's been I feel like a really successful project and pilot of kind of bringing together two different entities that now work very, very well together. So some of the other organizations on the phone, I'd love to hear your thoughts, experiences so far.
This is Sherry from St. Mary's, and we have not done any type of integration at all. We've talked briefly about it, so that's why I was interested in listening to your presentation today to get some more ideas and see how it might work for us.
Not to put you on the spot, but what have been some of the main barriers that you've had to integrated models or pursuing some of these ideas?
Hmm, that's a good question. Well, probably one would be lack of pharmacists available.
Okay.
However, the hospital now actually has a full-time employed pharmacist on staff. So I think that's part of what makes this, a piece that we could potentially look at. And probably really from my side of the coin, I'm fairly new to this particular role, having been in it only about 6 months. And we just now, oh gosh, within the last year, have actually hired a second behavioral health consultant to cover our St. Mary's side of the facilities. Clearwater Valley's had one for about a year and a half, maybe close to, yeah, I think it was a year in September. So we're really kind of new to the whole project or the whole idea overall. So just slow to get started probably would be the biggest piece, in all honesty.
Yep, that's actually a good response. I mean, a lot of times it has to do with available resources, whether that comes in the form of personnel or funding for projects like this. And a lot of times it's within an organization. One of the things that Jen and I have noticed is as these ideas come up, a lot of times a certain member of the staff or leadership is kind of tasked with building and strategizing and growing and operating all of it at the same time, which tends to be a huge lift. There's a lot of infrastructure that needs to go around these integration projects, and if you've got a full-time job on top of trying to build out another program, it a lot of times is an insurmountable barrier. So appreciate you sharing. Other thoughts, questions, comments from others?
Tyler, this is Anne.
Yeah.
I just wanted to mention I had heard from Stephanie's comment regarding how great of a fit Shelby was within their clinic and as far as the personality and is that something that when clinics start looking at this, I know for behavioral health folks there's sometimes the concept of good fit is also a consideration. Would that be your sensibility, or advice even to these other clinics who are considering this, that it may also be a really different type of pharmacist?
Absolutely. Fit's incredibly important. We've had this experience multiple times, and enough to know that I think in the context of behavioral health, and Jen, I've heard you and Anne describe this multiple times, and so I'm going to make an attempt, but I probably will get it wrong. So please have patience with me. But from the training of a behavioral health specialist, there's kind of that traditional mental health side, and really the practice of integration and the model of brief interventions within a clinic is sometimes a very, very difficult thing for even a very good clinician to adapt to. Excuse me. And I've found the same thing to be true with pharmacists. I can have a very, very good pharmacist who is incredibly intelligent and clinically very, very savvy, but the pace and the environment of a clinic is something different, and sometimes it actually plays into the culture of a clinic in terms of how providers and nurses and other members of the care team interact, and whether or not you're able to integrate well with that clinic environment, and roll with some of the things that are going to come your way. And I've found that sometimes you can coach that if a pharmacist doesn't have a lot of experience in a clinic, or has had most of their experience in a retail model. But I've also had the experience where I've taken a pharmacist from a retail model, and they were just the right fit for a clinic. They understood how to communicate. They understood how to build relationships, and that part has been incredibly important to the success of these integration projects. If we try to force it, or oftentimes pharmacists are very comfortable operating within a very clearly defined box. And a lot of times clinical practice, it doesn't necessarily fit, or we're having to think outside the box, or we're having to roll with different things on different days. And so it becomes a little bit of a difficult environment for that pharmacist to work in. And so I absolutely agree, and the fit is something incredibly important for a clinic to consider when you're thinking about this opportunity. So thank you. Other thoughts, comments from those on the phone or different organizations?
Tyler, can you hear me? This is Jolie up in Coeur d'Alene.
Yes. Hi. How are you?
Hey, good. Hey, so I am the clinical pharmacist up in an FQHC up in Coeur d'Alene, and I have been here for about 3 years. And so here at our clinic, we're actually quite well integrated. So I am a CDE, and I see patients on a panel, and I see a lot of complex diabetics, or I get geriatric consults, and I actually see them in an incident to meeting in conjunction with the provider, so that we can bill for it as a full office visit.
Nice.
Yeah, so we've been working on expanding this practice, but again, the biggest thing is there's only one of me, and we have 30,000 patient lives, so it's mostly just me at this one clinic, and I go out a half day a month to each of the other 3 sites and see patients. But I get drawn into behavioral health stuff a lot. Our behavioral health providers are here in the clinic, the medical clinic, so they'll walk over and ask questions and talk to me about complex patients, or just have discussions, but I'm not integrated into very much of seeing the behavioral health patients specifically. And then for the OUD patients, I mostly interact with those patients in terms of educating the providers on the appropriate way to see the patients and refill prescriptions, so they don't fall on my pharmacy tech, so that they are calling between appointments. So I try to get them to, educate them on appropriate use and appropriate, MMEs and stuff like that, but also scheduling refills to correspond with face-to-face visits and to minimize phone calls. So that's kind of what I've been working on here. And we do a lot of chronic care management too.
Yeah. So jumping ahead a little bit on the opioid topic, but I'm glad you brought up the importance of the coordination of the timing and the refills. Those are things that are often overlooked. But from the pharmacy side, and kind of from our pharmacy lens, a lot of times those float to the top as really immediate opportunities to help coordinate the care better, so that it doesn't end up as a problem on someone else's plate, 28 days from now. So
correct. Yep.
That's great. Thank you.
Yep, that's all I got.
All right. Awesome. Thanks for chiming in. Any other comments or questions before we move along? Okay. Really appreciate the comments and the interplay there, because that's really where I find it to be most valuable, is where we can actually dive into individual practices and understand what our opportunities and our wins and our concerns and our barriers are at different individual sites, so that it becomes much more applicable in a real world way. So okay, so switching gears a little bit in terms of opioid use disorder in the background. So you're not meant to read all of the tiny print on this slide. I just clipped this from the CDC, and really the point here is that I'd like to make is we find ourselves in this situation in the country right now, in the middle of this really tumultuous situation, where over the last 10, 15 years, well, yeah, I'd say back into the mid 90s was when this was really starting to heat up. But we've gotten ourselves into a situation that we now have the responsibility as healthcare professionals to try to unwind. This has been one of the most impactful things within my career in terms of seeing this pendulum shift, because I remember very, very vividly giving a lecture to nurses when I was a resident in my training, talking about how wonderful opioids were, because it was this highly effective medication and we had this strategy and we were going to use, you know, long acting opioids and layer on like short acting opioids for breakthrough pain, and the pain was the fifth vital sign, and it was really important to keep people comfortable, and oh my goodness, we have shifted so hard in the other direction now that we have seen some of the detrimental effects of getting patients started on these medications and then kind of setting it and forgetting it and not keeping a close eye on this. And so excuse me, basically just saying that this has had you know, really far-reaching impacts and massive morbidity and mortality impacts on our country. And especially in the Midwest and in the South, there's been communities that have just been really decimated from opioid use disorder and then illicit drug use and overdose deaths and things of that nature. So we have a lot to work on here. There's been a lot of really strong initiatives put forth from the CDC and other organizations, and we can dive into a lot of detail. But given the time frame and where I'd like to focus the conversation is really just the CDC identifies of their main 12 recommendations that they bring 3 to the forefront. And really the guidance here is that non-opioid medications are really preferred, except in a certain few conditions. And seeing those on the screen, those are, you know, end of life stuff, palliative care, cancer care. And there's always going to be those exceptions to the rules where a patient is a really good candidate for chronic long-term opioid pain control. But in most cases, we should be looking at non-opioid medications as the preferred options. When and if we're using opioids, always use the lowest effective doses and always prescribe cautiously and monitor closely. And this third bullet is to Jolie's point, when it comes to educating prescribers about you know, lowest MMEs and trying to taper folks down, or monitoring and making sure that refills are coinciding with visits. This is the type of monitoring closely that there's a real danger of things falling through the cracks, because in our healthcare culture right now, it's still one that heavily favors volume. So we're pushed for more visits per day and more widgets produced per hour. And that tends to shift our focus away from the ongoing monitoring and careful consideration and coordination with the patient to make sure that that they're aware of really the risks associated with this type of medication and how we want to use it very judiciously. So, excuse me, like I said, we've had a lot of initiatives over the last little while, you know, so how's it going? This is the most up-to-date information that I could find coming out of the CDC. This is what really concerns me. So we've got, if you draw your attention to this gold line of prescription opioids, you know, 3-4 years ago, we really started to see this push of ratcheting back on prescription opioids. And we had this dip. It was on a pretty good rise. And sorry, I skipped this, but this is number of opioid deaths by drugs. So this is looking at overdoses and deaths where drugs are associated. So we had this dip in prescription opioid deaths, but as you'll notice, right around this same vertical axis time frame, we started to see this increase in the blue line of heroin. And more recently, this purple line, which is very concerning to me, we've seen this almost straight vertical spike in fentanyl and synthetic opioids. So when we talk about opioids and we talk about potency, the fentanyl and synthetics, we're talking about medications that are orders of magnitude more potent. And so a lot of times, you know, if patients have been started on prescription hydrocodone or graduated to oxycodone or OxyContin, and then they you know, don't have access to the prescription any longer. A lot of times what we're finding is that they're switching to heroin or finding access points through a variety of sources to get their hands on fentanyl or other synthetics that are incredibly more potent and therefore more deadly, because if you get the dose wrong, it's much more impactful. So a few of the other things, not to dwell on the negative, but a few of the other things that have been effective. We've got further naloxone distribution. So the naloxone is that reversal agent that when someone has taken too much, but whether, you know, on purpose or by accident, naloxone can competitively bind and reverse for the opioid receptors. Buys us some time. And then there's also been, excuse me, investments in treatment availability in terms of substance use facilities, but overall in the country and in Idaho, we're woefully understaffed in order to deal with this right now. And so it's being pushed on a lot of primary care environments who don't feel that they have the adequate training. So we're, you know, there have been investments and progress in terms of treatments and availability, but it's still not meeting that demand. And I mentioned heroin and cutoffs in terms of coordination with payers. And the reason that I bring payers into this question is some of the third-party payers, when the opioid epidemic was really getting into full swing and the CDC's guidance came out, and we were trying to ratchet down on MMEs and reduce the total number of prescriptions written, there were some pretty harsh cutoffs put into place. Something to the effect of, you know, you've been identified as a patient who is filling X amount of, you know, opioid prescriptions or X amount of MMEs, or the prescriber was notified, and you had X number of weeks to either taper back to an appropriate dose or your medication would then no longer be covered. This hasn't been shown to be an effective strategy, because what happens is, you know, the clinicians are aware, if we get into a situation of opioid dependence, this is something that has to be unwound very, very carefully and very slowly in order to make sure that we don't send them into a withdrawal and a seeking cycle of, you know, if we're cutting off a supply of medication, they'll find an illicit source somewhere else. So they're starting to ease up on those insurance regulations. Been apparent that hasn't been a good strategy. So it's really about working with the prescribers, working with, you know, Board of Pharmacy, the prescription drug monitoring system, and really trying to meet patients where they are, and understanding that it is a gradual rather than a sudden cutoff that will be more effective. So pharmacy involvement and interventions. On that note, there's a lot that we can do as pharmacists, whether from the retail side, from the clinical side, hospital side, to assess and to consult, to communicate if we're seeing any red flags. Excuse me. From a retail side of things, at the pharmacy counter, a lot of times we'll see a different side of the patient, and this can be a very confrontational and contentious interaction, and one from my colleagues on the retail side that is just has been increasing over the last 10 years, and really a very difficult situation to deal with oftentimes, of folks coming in and looking for early refills on their meds, or saying that they lost them and they need an emergency fill. Really, at that point, it kind of behooves us as part of the medical community and part of the care team and the extended care team to use whatever resources we have at our disposal, whether it be checking through the Board of Pharmacy to monitor the prescription drug monitoring program, consulting and communicating with the patient's primary care provider so that they know what's going on, and really trying to support that patient and make sure that they have the resources available to them, whether they decide that this is the time that they want to take advantage of those resources or not. And then within the care team, similar to what Jolie mentioned, it's patient education, it's prescriber education, dose calculation, tapering. There's a lot of work that goes into this. It's fairly time intensive, and a pharmacist can really play a big role in helping you in these areas. So collaboration opportunities, especially within the context of opioid use disorder, really we're going to be in any excuse me, in any environment trying to coordinate with our colleagues in behavioral health. There's always some need there as we're looking at substance use. Working with primary care, as I mentioned, that we're underserved and understaffed to deal with this across the country. And so a lot of this work is being pushed back onto primary care providers. In the cases where we do have specialists for pain control or specialists in substance use disorder, those are excellent resources to plug into. And I've already mentioned the Board of Pharmacy from a prescription drug monitoring perspective. That's getting easier and easier to use. A lot of times that's being integrated into your medical record. So you have gateway access. It's a lot easier to check rather than logging into an external platform. And so that can also be a resource for you. So wrapping up there, questions on the context of opioid use disorder and maybe what you're seeing in your communities. This hopefully is going to be a topic that we address in further depth with upcoming webinars and getting into some of the strategies around screening and titrations, and then also just even some of the community cultural barriers that we might face. So questions or comments in the context of the opioid use dilemma, I guess, that we find ourselves in.
Tyler,
Yes.
this is Jen R. I'm curious from like a patient perspective, when you do have a pharmacist or care team that is, kind of too far on the pendulum swing and aggressively tapering somebody and possibly putting them at risk, for, in that way, do the patients have any resources available to them to like seek advice or an intermediary to discuss with the, their care team that might not be the best course of action?
It's a really good question. Me personally, I'm not aware of a resource that acts specifically in that capacity, but opening to others on the call, I don't know if it would be the role of potentially like a patient advocate or resource within social work or a local advocacy group or something that could act in that capacity. Has anyone else had any experience with kind of an intermediary for the patient?
Tyler, this is Anne, and to be quite honest, I haven't heard any of that intermediary type of service or kind of advocacy. I think that's definitely worthy to explore because, yeah, I mean, Jen, you pose a really good question. What then does a patient do, or on the lines of advocacy or connection to a greater resource? So I think that's definitely something that is. At least that I'm not aware of currently present within our communities, but here again, maybe others have an idea that I haven't even heard of.
And Tyler, I'd have to agree with Anne. unless the clinics themselves have some sort of a really robust care management system or some sort of a patient navigator, I don't think there has been any that I'm aware of.
The other thing that comes to mind when you mention a really strong care management or a really, strong care team around the patient, quite often the harsher cutoffs, and again, we're seeing these being backed off substantially. But if a payer is implementing these, a lot of times you have to understand that it's a electronic trigger that's placed. So they do dose calculations, and if it exceeds their threshold at all, that patient gets flagged. So quite often what I see in the context of other areas where we might need to pursue like an appeal or a prior authorization might get denied initially, but we have a strong care team around the patient that understands how they need to act in that capacity to appeal that ruling or kind of go above and beyond for that patient. A lot of times the payers, once you actually get through to a live person and coordinate with someone on their care team, they're able to make exceptions to that rule. It almost takes that care team to care team communication, in my experience, which if patients are left on their own, a lot of times it's not a good situation. Difficult to navigate, I guess, as a patient. So
Right. Yeah. Thank you very much. And I'm so sorry. I'm a presenter at my next meeting, so I have to jump, but really
great.
appreciate it. Thank
We're
you.
wrapping up. Thank you. Other questions or comments in the last minute here? Realize we went right up to time. Excuse me.
And if not, we'll wrap up. And if you have additional questions, field them to Anne. She's going to touch base with you guys on the information and getting feedback from you.
Okay.
All right.
Thank you, Tyler.
Thank you so
Appreciate
much.
Thanks,
it.
everybody.
Thank you.
Tyler. Appreciate it.